During the Social Ecology of Wellness class, we were tasked with completing a community needs assessment and then creating an intervention to help address the issue that we had identified. At the time, I was doing my practicum placement in a community mental health setting, and we were asking clients questions about their eating habits in order to use it as diagnostic criteria for depression and anxiety. But I realized that one thing that we were never asking the clients was, did they have access to food? Did they have access, or were they able to support everyone in their household, etc.? And so I became really interested in food insecurity and food justice as it relates to the population that I was serving in Marion County. So let's begin. So first, it's important to know that the population that I'm working with all qualify for Oregon Health Plan, and that means that they have to meet a certain percentage of the poverty level. So what is poverty? Poverty is defined as the state of being extremely poor, but the federal government breaks it down into more concrete numbers. So based on your household size, there is a certain amount of income that you can have in order to meet the federal poverty requirements. And in order to qualify for Medicaid, you have to meet 138% of the federal poverty limit. So that means if you're a single individual, then you can't make more than $16,753 a year. If you're a family of four, the cap is $34,638, which is not a significant amount of money to live on and does have a devastating impact on a family's ability to take care of their needs, especially when it comes to food. Now, as far as the poverty demographics in Oregon, according to the Oregon Center for Public Policy, in 2015, 15.4% of Oregonians were living in poverty. That's 607,000 Oregonians. And that's significant because living east of the Cascades, we only have 532,000 Oregonians. So that means that there are more Oregonians living in poverty than the entire population of Eastern Oregon. And the estimate was that by 2017, 3.2% or over 537,000 Oregonians would be considered to be living in poverty. Now, looking at the demographics, according to the 2017 American Community Survey, the most recent figures are that as far as the population breakdown, 25.8% of African Americans are living in poverty. Native Americans, 21.8% are living in poverty. Latino, 19.4%. Asian American, 14.0%. And then white or Caucasian, 12.4%. But if you remember from one of the previous slides, it said that 15% of Oregonians were living in poverty, and yet when we look at the numbers for people of color, the percentage is much higher. So there's a discrepancy there as far as reporting and then how interventions are crafted and put into place. Now, looking at the demographics for Marion County, which is where my internship took place, and that's the county of residence for all of the clients that are served by the agency I was working with, the population composition is 65.5% Caucasian, 1.5% Black, 26.7% Latino, and 2.6% Native American. But when we look at those same populations and the level of poverty that they're experiencing, 125% of the poverty level would still put them as eligible for Medicaid services. So we've got 15.9% of the population that's living in poverty are Caucasian, and then 43.3% are Black or African American, when that's only 1.5% of the total population of Marion County, which is disturbing. 34.8% of the people living in poverty in Marion County are Latino, and then 34% are Native American. So just looking at the comparison between the total numbers, I mean, there's 8,874 Native Americans living in Marion County, and 3,000 of them, over 3,000 of them, are living at 125% of the poverty level. So that's really quite significant. And if we're drafting our interventions to work under the premise that 15.9% or 15% is the poverty rate, then we're missing a huge percentage of people of color who could benefit from interventions. Now, looking at health disparities is important because food insecurity and poor nutrition can imitate other health conditions or be masked by disease, according to the Oregon Food Bank. So when we're looking at food insecurity and justice and creating interventions that support overall health and wellness, it's important to recognize that obesity, diabetes, and hypertension can all be directly linked to food insecurity or lack of adequate nutrition. So looking at these numbers, you can see how living in poverty directly relates to food insecurity and then can directly relate to your physical health as well. Because if you don't have adequate access to nutrient-rich foods, you're spending your limited resources just getting any kind of material that you can, and that may lead clients to purchase junk food, basically, chips and things like that, because they're more affordable than fresh fruits, vegetables, cuts of meat, and the more nutrient-rich foods. And then this can contribute to obesity, diabetes, hypertension, and other health conditions. So I've been using it a lot, but let's talk about what food insecurity actually is, okay? So hunger is defined as a feeling of discomfort or weakness caused by a lack of food coupled with the desire to eat. Food insecurity is the state of being without reliable access to a sufficient quantity of affordable, nutritious food. According to the Oregon Food Bank CEO, Susanna Morgan, hunger means worrying about having enough nutritious food, struggling to afford enough nutritious food, eating less food than your body needs. Food insecurity means the same thing. It's just the government term that is intentionally more academic and less emotional. There is an emotional charge when we talk about people that are going hungry. There is more emotional distance when we categorize it as food insecurity. And it's even easier to blame the people who are experiencing that condition because it makes it sound like something that they are failing to take care of on their part. If they have food insecurity, then they must not be doing enough to be food insecure. Whereas if they have hunger because of a lack of resources, that's not necessarily something that they're to blame for. So in Oregon, we are ranked 31st in the nation with a food hunger insecurity rate of 12.9% as of 2017. But when we were looking at the context of poverty, we know that those averaged percentages can be greatly misleading. So the Oregon Food Bank did an analysis and reported that 68% of households are at or below the federal poverty line. And this is people that are actually receiving services from any of the food bank partners or locations. 78% of the households that receive services have children that are living at or below the federal poverty line, and 75% of the households that are receiving assistance are Latinx and are living in poverty. So when we're looking at the poverty rates, and we know the numbers of people who are in need, and then we're looking at the percentages of people that are accessing services, there's a disparity there as well. And the research does not get into the specifics of what kind of potential barriers they may be facing. It just is very boiled down data. All right, so how are we currently addressing food insecurity? The primary program to provide assistance to individuals in need of food resources is called the Federal Supplemental Nutrition Assistance Program, or SNAP. It's sometimes also referred to Oregon Trail or EBT benefits, electronic benefits transfer. SNAP is an assistance program where eligibility is based on the income limits set in accordance with the federal poverty limit and follows household limits equivalent to Medicaid. So roughly, if you're living at 138% of the poverty limit, then you can qualify for the SNAP program and receive food assistance. So according to the Oregon Food Bank CEO, again, Susanna Morgan, SNAP is the single most important weapon in the fight against hunger. Through SNAP, 625,000 Oregonians get money each month on a debit card that can only be spent on groceries. SNAP brings nearly $1 billion of grocery purchasing power into our state through our rural grocery stores into the homes of our neighbors struggling with hunger. So SNAP is a very significant program that addresses food insecurity and helps alleviate hunger for the population of Oregon. But what's the historical context of SNAP? So originally, SNAP was not designed to alleviate hunger. It was designed to reduce unmarketable food surpluses. Farmers were growing so much food that was not able to be sold because of deflated market prices in the 1930s that the government instituted this program to bring food from the farms into the urban centers, and they would provide tickets or stamps for individuals to use to purchase food. And there were orange stamps and there were blue stamps. And orange stamps had a dollar for dollar value, whereas blue stamps had a 2-to-1 ratio. So for every dollar you spent to purchase blue stamps, you could receive $2 worth of food. But the blue food was specifically for those unmarketable food surpluses that were being brought in order to eliminate that surplus and the waste and support the economy of the farmers. It was so successful that they actually ran out of surplus food and eliminated the program. And then so the program was eliminated in the 1940s and then resumed in the 1960s after nearly 20 years of research showing that the original program had the unintended consequence of increasing health and wellness for the individuals who were able to purchase that surplus food and support their families. So then in 1974, the food stamp program was expanded nationwide, and there are still some differences in how each state chooses to implement it, but each state is eligible to receive the support of those federal dollars. By 1977, the Food Stamp Act officially established the national standards for eligibility and eliminated the buy-in or purchase requirement. That was that individuals were no longer required to purchase any part of the benefits with their own cash money. Prior to the 1977 Food Stamp Act, clients had it was very similar to the original implementation of the program. They would spend $1 to receive a stamp that was worth $1 plus any sort of additional percentage, and then they were spending those stamps to purchase food. All right, so then in 1984, electronic benefits transfer cards were first introduced as a way to reduce fraud, waste, and abuse. This was issuing people an electronic debit card where they would have a PIN that was strictly theirs. It was much more difficult for people to sell or trade their food stamps for cash when they were all contained on an electronic benefits card versus when they were paper stamps that they could trade for money. In the 1990s and early 2000s, legislation reshaped the ability and requirements of available benefits. And then in 2004, so 20 years after EBT cards were first introduced, they became mandated nationwide, and the use of paper stamps or coupons was completely eliminated. So some interesting things to consider about the reforms that were put into place were the impact that they had for communities of color. In 1974, the SNAP program was expanded nationwide to include the U.S. territories of Guam, Puerto Rico, and the Virgin Islands. But then in 1982, Puerto Rico was removed from the SNAP program, and it was replaced with a block grant, NAP, the National Assistance Program, that did not have the same support or structure that SNAP had, and ended up leading to abuses of funds by the government, because while they're supposed to use those resources for providing food assistance, with the block grant, they can allocate those funds to other areas. In 1996, the Personal Responsibility and Work Opportunities Reconciliation Act eliminated eligibility of legal immigrants. Now, we're not talking about people who are undocumented. We're talking about naturalized citizens. We're talking about resident aliens. We're talking about people who are legally in the country, but because they are immigrants and they are not born in the United States, this legislation eliminated their ability to access food stamp support benefits. In 1997-98, eligibility was restored for elderly, disabled, or children of immigrants who were living in the U.S. prior to 1996. So there's still barriers in the legislation. If you're an immigrant who has moved to the United States since 1996 and has become a naturalized citizen, you may not qualify for food assistance benefits unless you meet certain criteria. If you're disabled, elderly, if you're a child, and then they have some other criteria that you can meet to gain access to benefits. And then in 2002, the Farm Bill reestablishes eligibility for qualified aliens who have been living in the United States for 5+ years. But again, it's not fully accessible for all folks. There are many barriers that they have put in place to try to reduce utilization of these benefits by people of color. So the current impact of interventions. Oregon Food Bank has approximately 1,200 partners and other programs throughout the state who receive and redistribute food to community members. That includes county food banks that act as distribution networks for food resources, and also shelters and churches can utilize the resources and provide hot meals. Oregon Food Bank also partners with over 300 healthcare centers, or healthcare systems, to provide food insecurity screening to residents across the state, and then assist them with applying for food stamp benefits. So this goes back to how improper or reduced access to proper nutrition can negatively impact your physical health. And so Oregon Food Bank has taken steps to make sure that primary care providers and urgent care clinics are trained to provide these screening tools so that they can identify people who are experiencing food insecurity and then get them connected to resources to help support their overall well-being. So the intervention methodology that I designed for my particular population at the mental health clinic was to design and distribute a survey to establish the needs of the population related to the issue. Of course, that meant making sure that I was involving my participants in the shape of the research. So I needed to solicit feedback to shape and design the intervention. So that meant working with the trauma-informed care committee that has client members who are participants and help shape and design all of the materials that are publicly available through the agency. That they all have to go through the trauma-informed care committee and get feedback from the client base. Next would be to implement the intervention at the appropriate level. What this ended up meaning is that surveys were available at my specific location, which was the South Salem Office of Options Counseling, and the response rate for the survey was roughly 50%, which sounds impressive, but we printed 20 copies of the survey and I received 10 of them back, which honestly didn't even fit with the timeline of the project, because by the time the survey had finished the design and implementation process, I was already to the tail end of the semester, and so the intervention that I provided for the community, which I'll discuss later, was not based on the survey. But the positive aspect of creating the survey was that prior to my intervention, the agency was not asking clients about their access to resources or doing any sort of diagnostics around food insecurity. Now they have taken that survey and used it as a diagnostic tool, so it's available to all clinicians throughout the state of Oregon to be able to use it to screen their clients and determine if they are experiencing food insecurity, and then providing them with resources to help address that. So the last step of the intervention was to solicit feedback to determine the efficacy of the intervention. I did talk to the Trauma-Informed Care Committee about the intervention that I created, and I got a lot of positive feedback about the intervention. They said that it was very trauma-informed and accessible, and that they really appreciated the fact that it was going to be available throughout Marion County. So let's move on. I wanted my intervention not just to be a micro level intervention talking about the needs and abilities of the clients, but also mezzo level. So I worked with the agency, like I said, to coordinate the implementation of a screening tool so that clinicians are aware that food insecurity can be a big part of what's driving mental health stressors. I also, after completing my intervention, reached out to the Marion Polk Food Share and provided them with a copy of the resource guide that I adapted so that they could consider it for wide-scale public use and adapt it for their own purposes. As part of my research, I did a telephone interview with Cara D. Nassau from the McSilver Institute for Poverty Policy and Research in New York City. She is an LMSW. She also has a doctorate. She's working on a doctorate in social work, her DSW. She's got 15 plus years of experience researching poverty and food insecurity. She's currently focused on poverty and pregnant women. She utilizes participant action research in her design and implementation of services. She talked to me a lot about the mini pantry project that they did. It's similar to the tiny libraries that you see where there are cases that are set up on the corners of neighborhoods, and their intervention provided the stock resources to be able to start the project, but then community members actually add and subtract from the pantry. And so the idea is that it's not to support your full food budget, but it's one of those things where if you're trying to make spaghetti and you don't have any pasta, you can run down to the mini pantry and you can grab a bag of pasta, and then you can replace it with a can of corn or refried beans, something that you have extra and you're not planning on using it, or it's a food that your family doesn't particularly like, but other community members may benefit from it. She said that that actually ended up being a very self-sustaining project because the neighbors in the community felt empowered by it and took it on, and so they have successfully maintained that. And I believe that the neighborhood they were working with was in the Bronx in New York. She said the biggest challenge of any intervention is finding sustainable funding. Most grants will support a program for 1 to 3 years, but after that you're expected to be able to find your own sustainable funding. And she said that even effective interventions that absolutely do what they are designed to do and reduce difficulties for the population may not find sustainable funding because there's so many other research topics that are out there that the funding goes to new interventions to address other issues. So what she said was that the the graveyard of interventions is full of successful programs that just didn't have the funding to continue. And then she said that what her biggest support would be from future social workers would to see policy changes that support populations and programs through those funding sources. I also talked with her because I was, like I said at the beginning, I was very interested in this idea that we use appetite and eating habits as a diagnostic criteria for mental illness, but I couldn't find any information that anyone was actually researching those. And Kara confirmed for me that for pregnant women, because it impacts the fetus, and for children, they do research around food insecurity and eating habits in order to use those to support the interventions that they provide. But she said that as far as she knows, no one is looking at the impact of adult hunger with mental health symptoms. So that was really, really interesting to me that I had kind of touched on this area that isn't receiving adequate attention. Now, since I had spoken to someone who works with a very large urban-based population, I mean, she's doing her research on communities in New York City, which is one of the largest cities in the world, I wanted to see what was kind of at the other end of that spectrum. So I picked a small town to do interviews with the community resource providers. So the next interview that I did was with Cindy Rice, who has a self-designed degree in community support and development. But as she was describing it to me, it actually sounded like a combination of macro level social work and business administration, which was really, really interesting. She's been working in the community for over 30 years, and she helps run the Sweet Home Emergency Ministries, or SHEM, which has monthly access to the food pantry. And then they also do fresh fruits and veggies on a weekly basis. So once a month, families can come in and they can do a shop for the shelf-stable items and canned goods and dried goods. But every week they can come in and pick up fresh fruits and vegetables. For accessibility, their pantry uses labels that are in both English and Spanish, and they also have pictures of items for the non-English and non-readers, basically. In 2017, they provided services for 18,000 clients, and that is significant because the population of Sweet Home is only 10,000 people. So they're reaching not just the Sweet Home community, but also rural Lynn County, and supporting the smaller communities in the Cascade foothills. The biggest challenge that she identified for their supportive services was lack of peripheral resources. And what that means is there's no mental health support available in the community. There's no shelter services for people who are experiencing homelessness. There's a huge reduction in the availability of those kind of community supportive resources. So they're able to provide people with food, but then they have identified that those people don't necessarily have a home that they can take that food back to be able to cook it. And there's just a lack of social supports in the community. What she said she would like to see from the future social workers is the establishment of services that support other aspects of poverty. She said that they don't need additional help addressing food insecurity or justice, but she would like to see education support. She would like to see housing support, addressing the homelessness issue, and definitely addressing mental health supports, substance use, and addiction. I also spoke with Lisa Pye, who is the chairperson of an organization called the Sweet Home Gleaners. And she has been with that organization for over 10 years. Access to their services is membership based. So you can't just be a community member and come in and get services. You have to actually participate. It's similar to a co-op. and they go out into the community to local farmers and they collect the surplus food that will not be sent to market, and then that's redistributed to their members. So they have food distribution twice a week on Monday and Friday. They also receive resources from the Oregon Food Bank to distribute as well. They measure their program success in pounds of food that are distributed. So as long as the food that is coming in is distributed and they are kind of balancing out with I think she said less than 5% food waste, because fresh fruits and vegetables don't last forever. But they don't throw anything directly into the trash. Any vegetables or food products that are not fit for human consumption are distributed to the local farmers who use them as a feed source for animals. Clients who receive services with the Sweet Home Gleaners are equal partners, and they have 5 board positions that are voted through annually, so that the clients are actually serving on the board and deciding the direction and organization of the agency. She said that the biggest challenge that they face is finding volunteers and able-bodied members who can actually go out into the fields and do the food collection, who can lift and work and collect the food boxes, because they do distribute food to a large number of people who are elderly and disabled, and so they're looking for just people, just warm bodies that can show up and help them with the physical aspect of their distribution site. So after I had conducted my interviews, I had a better idea of what kind of interventions were being created at this huge urban level, and also at the smaller rural level, and then kind of had a general idea of what was being done and what was available in the state of Oregon. So we proceeded with the survey. I met with the Trauma-Informed Care Committee. They gave me suggestions, and we adapted the survey based on their suggestions. It was put into circulation. The leadership team decided to use it as a screening tool so that it is available throughout the agency. And then I started work to identify community resources that were available to create potential partnerships. The future possibilities that I was looking at that time were creating a resource guide to help raise awareness of the resources in the community that were available, looking at potential skills training if it was an area that was identified as a gap or a deficit, either providing cooking classes through the mental health agency or partnering with community agencies that were already providing those resources and establishing a referral network so that our clients would be able to access cooking classes and be able to improve their skills so that they could feed their families. Increasing education, there was talk of creating a recipe guide that people could share, and also potentially creating food pantries in the office locations. I would like to say that all of these things are still being discussed by the leadership committee, and there is talk of doing a larger scale survey to be able to identify what the community needs are around each office location, and then selecting the appropriate intervention. But for my purposes, because of the limited time available during the semester, I created a resource guide that cross-referenced the available food pantry locations listed in the Marion Pope Food Share Guide with the bus routes for Woodburn and Salem, in order to create that cross-reference and help clients figure out which buses they would need to take in order to access the different food pantries. So part of the project was creating this intersectionality model that identified the different factors that are impacting individual clients. And so the ones that I felt were most impactful for food insecurity with my community were poverty, transportation or lack thereof, the particular diagnosis that the clients were receiving. For example, depression has a component in the diagnostic statistical manual that asks about appetite and eating habits. Anxiety and other diagnoses don't even have that awareness that it may be a factor. So understanding what clinicians are asking and what they're looking for when they're doing their diagnostic criteria was very important to me. Ethnicity, language, and gender were also important because those different aspects can impact a client's ability to access help and their willingness to access help. There were also personal beliefs that were impacting them, family beliefs and dynamics that were impacting them, the larger agency culture and the policies and limitations that we have. We're not a food resource provider, we're a community mental health agency, and so there were a lot of limitations about what services we should even be attempting to provide in order to address this issue, to make sure that we were working within our scope of practice. And then the larger cultural and social factors and limitations, such as how often you can actually access community resources and receive food support in the community. So just looking at all of those factors and identifying that those are the primary barriers that we're facing when we're looking at getting clients more consistent access to food resources. So my project methodology was to speak with stakeholders and secure their support. So I met with the leadership team at the agency and the Trauma Informed Care Committee to make sure that the agency was in support of my project and that the clients were actually interested in this being something that would potentially be implemented and impact their lives. I incorporated the feedback that I received from those components and adjusted my approach. My next step was to raise awareness of the issue. So that meant educating agency staff and then providing tools and resources that they can utilize in their own individual interactions with clients. And then the implementation, the access to the questionnaire, and then ultimately providing access to the resource guide so that it could be implemented at the appropriate agency locations. And then just the ongoing improvement of service interventions, continuing that education piece so that new clinicians are being trained that food insecurity needs to be something that they are looking for when they are discussing mental health issues with their clients, because lack of adequate nutrition, lack of food resources can absolutely impact the mental health symptoms that they are seeing and experiencing with their clients. All right, so just a little background information about my my placement with my practicum where all of this was taking place. I was with Options Counseling and Family Services, specifically at the office on Southeast 12th Street, which serves the adult outpatient population. Options was founded in 1991 and serves low-income individuals and families in 11 counties in Oregon. So they go from the coast all the way to Bend, and then from Portland all the way down to Roseburg along the I-5 corridor. Part of their mission statement is that in partnership with members of the community we serve, Options Counseling and Family Services promotes safety, healing, and empowerment for individuals and families. I really like that because it doesn't specifically focus on mental health. It's really talking about all of the social determinants of health and the individual and family well-being, and helping to support them to kind of live the lives that they're trying to live. And so my project actually really fit with the mission statement of the organization, identifying a need and then helping promote empowerment and healing for individuals. Their vision statement, Options Counseling and Family Services, supports the health, safety, equity, and well-being of our clients, families, employees, and communities. So again, my project and my approach, my research questions were all really in line with the direction of the agency, and I received a lot of support from the agency in order to help identify and improve treatment approaches for our clients so that we can support that equity, health, and well-being. So this is an excerpt from the research or from the resource guide that I actually created. So what you can see is that there's a little bus symbol, and then it has a number or a series of numbers next to it with a plus sign, and then a little figure of a person walking, and then a distance. So what this means is, for this example, on the top here, to get to the Southeast Neighborhood Community Center, at 410 19th Street, Southeast Salem. You can, from the bus depot at the main transit hub, you can take either Route 4 or Route 7. And then from the nearest bus stop, you have to walk a third of a mile to reach the location. When looking at this one right next door to it, you would take from the transit hub bus route 17 to get to City Vibe, the Salem United Methodist Church at 1219 3rd Street Northwest, and the lack of distance means that the bus stop lets out right next to the location of the food pantry. So similar things for the Kaiser Community Dinner, and then the St. Vincent de Paul Society, they have a bus stop right next to their location. But any of these others, you can see that the Spanish Seventh-day Adventist, you have to walk over half a mile from the bus stop in order to reach the food resource. And that makes a difference, because if you're receiving 2 or 3 large boxes of food that's supposed to feed your family for a month, and you're relying on public transportation as your means of getting around the city and accessing the resources, then it's important to know that you need to take bus 12, and then you're going to have to walk over half a mile to get to the location, and you're also going to have to walk that same distance back to the bus stop carrying these large quantities of food. So it gives the client and their family an ability to kind of coordinate, to make sure that they're planning to have enough people available, either friends or family members, that can help transport the resources that they're getting. Otherwise, they're limited to what they can take from the resource by what they can actually physically carry back to the bus stop location. And you're only allowed to access food pantries once every 28 days, regardless of the quantity of food that you receive. So if you go to Seventh-day Adventist and you only take 1 box of food because that's all you can carry, that's the only food resource in Marion County that you can access for the next 28 days. So it has a really significant impact on clients' ability to plan and access the food resources. So the relevance of this project for social work, I made sure that I had a holistic, inclusive approach. I wanted to make sure that the services that I was suggesting were actually things that were relevant to the population that I was working with. I made sure that it utilizes resources that are already familiar to the population. Most of them are very familiar with the transit system. They use it to access other appointments and other services. And so by making the central hub for Salem and Woodburn the main location in reference to the food pantry locations, I was utilizing a knowledge network that they were already familiar with, so that they don't have to learn any new or additional skills in order to be able to support themselves, but they're just using skills that they already are familiar with. So that has that extra element of strength and empowerment. My project really underscores the importance of knowledge and education for service providers in the community. When I was in the implementation phase and had created the resource guide and was talking to my fellow clinicians at my placement location about the distance from our office to the nearest bus stop, none of them knew that the closest bus stop for our clients is a quarter of a mile away from the office. This became actually very significant over the winter when the weather got bad and it was cold and dark and raining. Our no-show rate increases significantly during those months. And I was able to help the agency understand that part of that no-show increase is because of the distance that clients are required to travel on foot in order to attend an appointment. They have to walk a quarter of a mile from the bus stop, and that's not taking into account any walking that they may have to do from their residence in order to reach a bus stop on their end of the transit adventure. So it really helped to raise awareness of the barriers that our clients are facing when they're accessing treatment and services, and also to educate my colleagues about the resources that are available in the community. It really helped to improve the working alliances that we have as an agency with other community partners, but also with our clients by providing them with a resource that emphasizes their knowledge and their ability and gives them that strengths perspective and empowers them to help support themselves. I got a lot of positive feedback from clients that was really appreciated because it didn't assume that they didn't know how to take care of themselves. My assumptions were that they were doing the best that they could with the knowledge they had, and my goal was to just increase that knowledge to improve their performance. It decreased injustice by reducing biases through education. Like I said, with that no-show rate, clinicians can sometimes really personalize that and put it back on the client, saying that they're not engaged or interested in treatment services, instead of looking at the barriers that are there with the weather and the other transportation factors that may limit client engagement. It's not that they don't want to be there, it's just that the barriers that are present in their lives are significant, and we need to help understand that. And it also opens up conversations for future interventions and partnerships. We're currently in discussion about how to proceed with the information that we have gathered. The resource guide is available in our agency to clients and community members alike. People can walk in and request a copy. The resource areas have copies posted and available, but also talking with other community providers, talking with the food bank, talking with the skills trainers from Oregon State University that offer cooking classes at no cost, and trying to figure out the future partnerships and what the best interventions are going to be to help support our population. That's something that has been created and is still ongoing, and I'm really proud of that impact that I've had on the agency. Some things that we need to consider when looking at all of this information is that current interventions assume that clients are sufficiently able-bodied to collect and transport food resources. If you are in a wheelchair and you are utilizing public transportation to go and collect a food box, your ability to collect and transport the resources that are available are going to be reduced and limited, especially if your only available option is one of those locations where you have to travel at least a quarter of a mile up to a mile from the nearest bus stop to be able to transport your food items. Going off of that, it is often assumed that personal transportation is going to be available for clients, which is usually not the case. So when food banks are providing a once a month shopping experience that results in, 2 to 4 large boxes of food, it's great that that quantity of resources available, but how are you supposed to move that amount of food using public transportation, especially if you're the only individual in your household that's able to go and do those things? Trying to relocate 3 or 4 boxes of food from the food box location back to your residence without personal transportation is burdensome. DHS SNAP offices and food distribution locations are not set up to be child friendly. If you are a single parent or your partner works and you're responsible for childcare, there is no childcare. So I have been at food box locations as part of some previous employment options that I was working with, where I didn't work for the food box, but I was there with a client to support them in gaining resources, and other clients were there with small children, and they were not allowed to take the children back with them into the pantry because they were considered to be too disruptive. So the option that these women had was to leave their toddlers alone in the waiting room while they went back to complete their shopping experience, with no support or childcare options from the staff at the food pantry. It was left up to the children to kind of monitor themselves and the other clients in the waiting room to help monitor and distract these children. So at one point, a woman was actually told by staff that she would need to leave and come back when she had adequate childcare, and I don't believe that's appropriate. The system is set up primarily to support English speakers. There are very few, if any, bilingual staff available at the locations. The posted material is generally available in English only. Food labels are in English. At best, you may find some Spanish language translations, but if you are not English or Spanish speaking, if you speak Swahili or Hindi or some other language, there's no support available. They don't have translation services. They don't have interpreters available. You have to bring your own translation services with you in order to gain access to these resources, because they are very, very biased against non-English speakers. Not that the individuals or staff are biased against them, but just that the language options available do not support that level of communication. Most of the food resources that you receive when you access a food pantry assume that you have access to cooking equipment. You're getting raw meat, you're getting raw eggs, you're getting fruits and frozen fruits and vegetables, things that they assume you will be able to take home and reheat and turn into something edible. There is not a lot of ready-to-eat items. It also assumes that you have access to store perishable items in a safe way in order to maintain them for, 28 days. So if you receive a gallon of milk and a dozen eggs and don't have a refrigerator or any way to keep those cool, they are going to spoil before you're actually able to utilize those food resources. So there are some assumptions and gaps in the service provision that are not being adequately addressed. The current resources also assume that you'll have sufficient skills as an individual to prepare the ingredients that you're receiving. If you don't know how to, a great example is dry beans, right? So if you receive a plastic bag of dry pinto beans, most individuals that, especially the ones that I have worked with in my skills training positions, did not understand that in order to adequately prepare that food as an edible resource, you needed to soak the beans overnight and then boil them for several hours in order to get them to a place that they would be soft and edible. And so the clients that I was working with would just refuse to accept any kind of dry bean because they didn't know how to work with it. And there are not instructions or any kind of tips for how to cook and prepare the majority of the ingredients that they're receiving from the food box locations. So it assumes a high level of skill and proficiency with being able to identify ingredients, know the proper way to cook them, and prepare them to be edible food. Food box locations have an extremely limited time frame to access them. Most of them will say that resources are available all day. For example, St. Vincent de Paul does food distribution from 10 a.m. until 4 p.m., which seems like a significant amount of time. However, if you're working a regular day job, you are not available to access those resources between 10 and 4. So that's an immediate barrier to receiving services. You also need to consider that if you're using public transportation, you have to account for the transportation buffers. So you can't leave at 10 o'clock to go and access these resources. You really need to be there ahead of time. There's also a significant wait period. I have spent 3 hours at a food box location with clients waiting to access resources. We arrived at 9:30, got signed up before the distribution began, and still had to sit and wait because there were a significant number of clients that had arrived before us. Again, for example, at St. Vincent de Paul on Portland Road, you can sign up for you can sign up for the pantry at beginning at 9 o'clock in the morning, but then they don't open until 10, and they only allow 40 shoppers because they have to monitor the amount of product that they have and make sure that it's fitting with their distribution obligations. So if you show up at 10:30 and there are 40 people ahead of you, even though the location has just opened at 10 o'clock, you will not be able to access resources at that time on that day. And so if you're having to take time off work to go to a food pantry location that is not a 100% guarantee that you'll be able to access resources, that can be very significant, and it can reduce clients' ability to access the resource and also their desire to access the resource. They want to be able to eat and feed their families, but they can't miss work to go to these locations to receive support. And then there's the limit to the frequency of how often you can actually access these resources. If it's an Oregon food bank location, they are required to report back to the food bank the names and demographic information of the people who are accessing their resource. That goes into a network that is being tracked to some extent, and there's a 28-day restriction. So if you go to St. Vincent on the 5th of the month, then you can't go back until the 3rd of the following month. You have to wait the 28-day window. If you do attempt to utilize resources at a different location and go back to the same location, they check it against their own list to see if you have been at that location within 28 days. So that it actually encourages clients that are experiencing a high degree of need to engage in a certain amount of dishonesty and figure out which food pantries they can access at different times of the month. So let's say they'll go to St. Vincent on the 5th of the month, but then by the 20th they need food again, and so they'll go to Helping Hands and utilize a food box there. So the individual sites are very strict about the 28-day limit, and then they do report the information back to the food bank, who can consolidate those lists and determine if fraud is occurring, and then a client may lose access to resources altogether because they were accessing food resources at multiple locations in order to ensure that their families were being fed. So there's a lot of potential barriers and unintended outcomes when we're trying to protect the resources and make sure that they're being utilized appropriately. We're also screening out people who may be experiencing the highest need, and there's no current system in place to make any sort of exception to make sure that people are getting their needs met. So that's all very significant things that I want people to keep in mind as we're moving forward and creating interventions and working with client populations to ensure that we're supporting the best practices and interventions possible. Here you'll see the start of my references. I believe that I have 4 slides. There are a lot of them. I'm going to just leave them up for a few seconds. My recommendation is that if there's a resource you're particularly interested in, please pause the video, write down the resource information, and then educate yourself, look into things. There was a lot of interesting information that I found. Again, please pause the video if you're interested in looking deeper into any of these resources. All right, this concludes my presentation. Thank you for your interest in the subject. Thank you for taking the time to listen to the different information that I found and for your interest and support in the resources that I have provided. You can contact me via email, which is listed on my resume in another portion of this portfolio. If you're interested in receiving a copy of the resource guide that I created, I'm more than happy to share that. And I did send a copy to the Marion Pope Food Share in hopes that they will incorporate that into their website and utilize that as the resource for the larger community. Thank you.